but we'll get started. Hi, everyone. It's August. We just keep moving along. But I'm very excited today to introduce Al Liu, who is someone that I've gotten to know over the years through prep work together and separate, and just have watched him in awe and everything that he's been able to accomplish. So I will describe him. Dr. Albert Liu is the clinical research director of Bridge HIV within the San Francisco Department of Public Health and associate clinical professor of medicine at UCSF. His research focuses on the safety and effectiveness of PrEP agents, strategies to monitor and support PrEP adherence, and how best to implement PrEP in real-world settings. He is an investigator within the HPTN, the HIV Prevention Trials Network, Microbicide Trials Network, and the newly formed COVID Prevention Trials Network. He also serves as co-chair of the PrEP Committee of the San Francisco Getting to Zero Consortium and a member of the UCSF IRB. Dr. Liu is a board-certified internist and is currently an attending physician at San Francisco General Hospital. And with that, I will turn it over to Dr. Al Liu. And please, everyone, put questions in the chat for general consumption, or to me if you'd like me to ask it privately or not from you. And Al, I'll turn it over to you now.
Okay, thanks so much, Jill. Thanks for that really kind introduction, and it's been such a pleasure to get to know you as well over the years. So I'm really thrilled to be here to share a talk called People-Centered Prep, and I'll be talking about a few innovative approaches to supporting PrEP use in vulnerable populations. These are my disclosures. So just an outline of what I was going to cover today. I was just going to briefly start with reviewing the latest trends and patterns of PrEP use, both globally and the US, and both talk about how that's promising, but also that there are a number of disparities that are concerning. Then we'll talk about the concept of people-centered PrEP and some recommendations around that. We'll then cover some innovative PrEP support strategies that are currently being researched, as well as some novel PrEP delivery models that are being tested. Then I'll talk about an approach that we're starting to take to support equity-based PrEP implementation in the Bay Area, as we're trying to develop a regional approach to PrEP implementation. And then I'll end with this idea of developing an anti-racist approach to PrEP. So the good news is that PrEP uptake is increasing globally, as well as in the US. And on the left here, this graph shows regional PrEP initiations over the last 5 years. It was presented by Kate Siegel from AVAC at the HIV R4P conference this year. And these are data from the Global PrEP Tracker, which you can see at prepwatch.org. And you can see that PrEP initiations have been on the rise from 2016 to 2020, with the highest number of initiations in 2020 in sub-Saharan Africa, as well as North America, and a particularly precipitous increase in sub-Saharan Africa, which are largely due to PEPFAR efforts. In the US, PrEP use has been also increasing a little bit more slowly, with currently over 200,000 PrEP users across the nation. And the scale up of PrEP has been associated with substantial population level reductions in HIV infections. These are data from Andrew Grulich in Australia, where they have had a rapid expansion of PrEP rollout through different demonstration projects and rollout programs. And these are data among MSM in New South Wales. And you can see that, over this period that they had a really steep increase in the number of PrEP users. And concurrently with this rollout, they saw a 44% decline in new HIV infections in New South Wales. And this PrEP implementation rollout was on top of high levels of ART coverage. So in the US, the CDC has estimated that there are more than 1.1 million Americans that could benefit from PrEP. And this includes gay, bisexual, and other men who have sex with men, heterosexually active adults, as well as people who inject drugs. And we saw on the previous slide that unfortunately, there are only about a fifth of these individuals are actually on PrEP. And there's also significant disparities, particularly by race, ethnicity. And so based on prescription data in 2015, 2016 from the CDC, they showed that while 44% of the people who could benefit from PrEP are African American, which was about 500,000 individuals, only 1% or about 7,000 individuals were prescribed PrEP. And similarly for Latinx, 25% or a quarter of those who could potentially benefit from PrEP are Latinx, but only 3% of those, or 7,600 Latinx, were prescribed PrEP. So really significant disparities here. And these are data from Amiko Kamitani and colleagues from the CDC. Looking at more recent data. This is a systematic review and meta-analysis of different published surveys of PrEP use among key populations in the US. And they were looking at trends over time. So they looked at the pre-PrEP guideline era, 2004 to 2014, compared to the post-PrEP guideline era, 2015 to 2017. And the open diamond is the pre-guideline era, and the solid black diamond is the post era. And what they did was they looked at growth rates across these periods. And so you can see first, overall growth rates did significantly increase from the pre-guideline period to the post-guideline period. So that's going in the right direction. And you can see in the pre-guideline period that the proportion of PrEP use grew significantly across all key populations. So above 1, you can see that these are odds ratios. Most of them were above 1, except for transgender women. Here, the odds ratio was 0.29, as well as people in the South. The odds ratio was 0.99. So then looking at the post guideline period, which is in the solid, again, the solid diamonds, there you can see that there were increases in Latinx, MSM, African Americans, as well as transgender populations going from the pre to post guideline period. And most of these were, the odds ratios were above 1. I think what's particularly concerning is that if you look at youth, they were actually doing fairly well pre-guideline period, with a odds ratio of 1.48. But in the post-guideline period, they're actually allowed less than 1 with an odds ratio of 0.82. So there are multiple barriers, both structural and intersectional barriers, that contribute to these disparities in PrEP uptake. These include stigma, racism, discrimination, medical mistrust, lack of access to medical care, transportation barriers, food insecurity, COVID restrictions, lack of insurance, including barriers for youth using parental insurance, and cost. And in addition to these disparities around PrEP uptake, we also see that there are significant issues with PrEP persistence, or staying on PrEP. So this slide shows PrEP persistence rates at between 6 and 12 months across a number of different settings. And you can see that across many of the studies, the drop off is pretty substantial. And so by 6 or 12 months, half or less than half of folks are still continuing on PrEP. And the concern is that a number of studies have shown that HIV risk continues even after oral PrEP is stopped. At our local STD clinic, we have seen a number of seroconversions after PrEP discontinuations. In a Montreal cohort, they also saw high rates of new infections after stopping PrEP. And in this study, you can see that HIV incidence rates were substantially higher after stopping PrEP in both Los Angeles and San Francisco. And what's also concerning is that many individuals who stop PrEP actually do not speak with a provider before discontinuing PrEP. So it's sort of happening on their own. Additionally, the lack of PrEP persistence can also accentuate disparities. And these are data from the 14 San Francisco primary care clinics showing differential rates of PrEP discontinuation over time, with the lowest rates of continuation among Black and Latinx individuals. And what are the reasons why people stop PrEP? Across a number of studies, these are sort of the top 6 that come out, including low self-perceived risk, cost or changes in insurance or medication coverage, medication side effects, either actual experienced or anticipated side effects, pill fatigue or just getting tired of taking a daily pill, difficulty adhering to provider and lab appointments, and stigma. So moving to people-centered care and the idea of people-centered PrEP. So this is grounded in the belief that people are equal partners in their care, and that they really are the center of decision-making and are the experts of what they need. And this approach is one that respects people's desires, values, family situations, social circumstances, and lifestyles. And it values people's point of view and being respectful. And I think what's central around this is that the services are really flexible to meet the needs of people in a manner that's best for them, rather than prioritizing needs of the system. And also the idea that we're doing things with people and not to them. So I'll start with 2 recommendations around how we can promote people-centered PrEP. And the first recommendation is really trying to focus PrEP counseling around the benefits of PrEP. And so in addition to the obvious benefit of reducing the risk of HIV acquisition, which is important, it can also be helpful to counsel patients about other benefits of PrEP. And a number of studies have shown that PrEP can reduce people's worry or anxiety about HIV, increase intimacy with partners, improve one's sex life, as well as enhance feelings that one is agency or feeling in control over one's sexual health. And, I think that the traditional messaging around PrEP, and we were guilty of this early on as well, that, the traditional messaging really focused around people being at very high risk for HIV. And that was, how PrEP was pitched. And I remember at one of our participants said, when they read the results of our study, they said, I don't think I'm, I don't see myself as a very high risk person. And so, people don't necessarily identify that way, and it pathologizes normal, healthy sexuality. And it highlights a difference between an individual who proactively chooses to use PrEP versus being targeted as a PrEP candidate. So, focusing on what PrEP can do for you can actually be really empowering. And this is data from a PrEP demonstration project in New York led by Sari Golub that showed, so this is looking at measures of anxiety, depression, as well as sexual compulsivity, comparing baseline in the gray and 6-month follow-up in blue. And you can see that with PrEP initiation, there were observed decreases in anxiety, depression, as well as sexual compulsivity. And one campaign that I think has really done a beautiful job of highlighting this concept is the Prep for Love campaign developed by Jim Pickett and others in Chicago that really celebrates the positive benefits of PrEP on fostering connection, intimacy, and passion between people. The second recommendation is to offer PrEP to all who desire it. Using this approach, PrEP can be offered as one option to choose as part of one's HIV prevention plan. And for this model, the goal is to help patients identify which methods might be a best fit for them into their sexual lives. And so in a review by Sari Golub and Julie Myers in New York, they call for a redefining of the PrEP eligibility assessment process. We've seen across a number of studies that it's often difficult to identify which patients are appropriate for PrEP. And this is a critical barrier to PrEP access. And often individual behavioral factors do not predict seroconversion. Examples include the high HIV incidence we see among Black MSM, which is not explained by individual risk behaviors. And also Erin Wilson here at our health department has demonstrated that if you use the CDC criteria alone for identifying transgender individuals for PrEP, that you would actually miss a lot of people who could benefit from PrEP. And so an alternative approach would be to present PrEP as an option for all sexually active people as a potential way to protect themselves from HIV. Part of this could include a discussion about whether PrEP would be a good fit for them, focus on the patient's needs and wants, and really de-emphasizing the role of the provider as a decision maker and gatekeeper to PrEP. So now I'm going to move on to talk about some PrEP support strategies that we've been investigating. And to start with, one approach that we've taken is to leverage mobile health and mobile phone technologies. I do think that these technologies offer enormous potential to reach and engage sexual and gender minorities, especially youth. We've seen pretty much a ubiquitous uptake and availability of technology. Over 95% of Americans own a cell phone, and particularly youth, African Americans and Latinx individuals are more likely to download apps and use their phone to access the internet. And the benefit also is that technology interventions are scalable and easy to disseminate. So one approach that we've been testing over the last a few years is an intervention called PrepMate. This was adapted from the WellTel model that Richard Lester in Vancouver has developed and tested. It's a bidirectional SMS platform that has weekly check-ins, and he had originally tested it in to support antiretroviral adherence in Kenya, and showed that it did indeed improve adherence as well as viral suppression. And it's a very simple model, checking in how are you doing, and people can respond that they're doing okay or not okay, and then they get triaged for additional services and help. And so we adapted this for PrEP and included some more tailored messaging around PrEP as well, and found that when tested in in collaboration with Sybil Hosek in Chicago among young, mostly Black and Latinx men of sex with men, that we did see a positive impact. And so this is looking at the proportion of individuals who had protective tenofovir diphosphate levels across the 9-month study. And across each visit, we do see higher levels of protection at each follow-up point, with an overall doubling of individuals having protective levels across visits. And we did not see any difference in efficacy based on age, race, ethnicity, education, or insurance. And this was a quote provided by one of the participants who talked about, why it was helpful, and said that, the sense of having somewhat a total stranger watching out for another person was great to have. Jen, who is the study coordinator, was that total stranger to me, and her and I developed a pseudo friendship through PrepMate. Her weekly check-ins gave me a sense of community and camaraderie that can sometimes be lost in this day and age. So it's this idea that you have a connection to the clinic and to staff that can be available for support was helpful. Another mobile health strategy that we've been developing and testing is sort of a different model, and this is more of a self-management model, where we've developed a mobile app that individuals can use to track their PrEP pill taking. It does provide customized reminders at a time that people want to take their pill, so they can track their pill taking as well as their sexual behavior. And it provides them feedback about their level of protection from PrEP based on their last last week's dosing. So you can see it's color coded, either no or low protection in red, yellow protection, or medium protection in yellow, and high protection in green. And we have so far completed pilot studies of this app showing that most individuals felt that this app.diary helped with taking PrEP. Most people liked using the app, and that reported that they would want to continue using it in the future. So what we're doing now is through a study funded by PCORE, which is a patient-centered outcomes research institute, we're actually doing a comparative effectiveness study comparing PrepMate, the SMS-based intervention, with this .diary app. And we hypothesize that they act through different mechanisms of support, which we'll be measuring, and ultimately, hopefully both supporting PrEP adherence and continuation. So we'll be looking at this in a study of 300 participants, which will be randomized 1-to-1 to PrepMate or .diary and followed for 12 months. Our collaborating partners are the San Francisco AIDS Foundation, the University of Miami PrEP Clinic with Suzanne DeBlecki-Lewis, and the Whitman Walker Health Clinic in DC. So that we just enrolled our first participant 2 weeks ago, and so we're excited about getting this underway. We also know that that novel PrEP regimens that are either available or on the horizon could also help with increasing PrEP starts and restarts. And so here are results from an online survey we conducted among MSM and transgender women in the Bay Area. And we asked them about several new modalities, including 211 or on-demand PrEP, long-acting injectable PrEP, as well as pericoidal rectal formulations, such as a douche or suppository that contains PrEP. And what we looked at, whether if they were offered these new strategies, whether it would encourage them to start PrEP, or if they had previously discontinued, whether they would restart PrEP. And what we found was that among those who had either never used PrEP or were not interested in daily PrEP, that about 3/4 would actually consider starting on-demand PrEP. And also, among those who had stopped, that this would encourage them to restart. So this really suggests that offering additional options can both increase PrEP uptake as well as PrEP persistence. We also saw substantial interest in injectables as well as, to a lesser degree, but definitely a considerable minority were also interested in topical rectal formulations. So one thing that we are currently developing, we've heard from a lot of folks that on-demand PrEP is an appealing option because they may either, not be having sex as frequently, and this was particularly the case during COVID. And so a number of people have switched to 211 PrEP. And the San Francisco AIDS Foundation currently is offering, 211 PrEP and daily PrEP in an even-handed way. And so people can choose either one or the other. And I think about 1/3 of new starts are choosing on-demand PrEP. But it is a more complex regimen to follow. And so we are currently developing an app to try to help support people taking 211 PrEP. And some of the features will include sort of this countdown clock that, once they take the PrEP, that they have 2 hours before they are protected. And it will, remind them when they need to take their follow-up doses. They can also track their, it's sort of an adaptation of the Diary app to include 211. So they can track their sexual encounters. And it provides them feedback about, the days of the week that they're having more likely to have sex and what proportion of their sex acts are covered by PrEP. It'll also have a section that can help people decide whether they want to switch between regimens, between daily versus 211, because we do see a fair amount of switching back and forth as, people's, seasons of risk. Now, as you may remember, one of the reasons why people stop PrEP is because they no longer think that they are at risk. And so we have Susan Buckbinder, Hyman Scott, and others have developed there are a number of risk assessment tools out there. And so we've developed one called SexPro. And this is it's been validated or developed based on a number of large cohort studies in MSM. And it's an interactive online tool to help individuals calculate a SexPro score, which is sort of a personalized HIV protection score. It's on a scale of 1 to 20, and it's a positive frame, so the higher the score, the better. And we have piloted this now in 240 MSM across the North and South America, and have found it to be easy to use, desirable, especially among young youth. And so this is actually a tool available now if you go to mysexpro.org, and it's available in English, Spanish, and Portuguese. And we've actually incorporated this tool into a number of apps that we're currently testing. This is another app that we're testing through the Adolescent Trials Network called Links. This is more of a focus around HIV testing, so you can order kits that are delivered to your home, or use geolocated maps to find local testing or PrEP sites around you. But you can see that SexPro has been incorporated into this as well. So also, in addition to supporting patients taking PrEP, I think it's also important to support the providers. And this is a study that Padia Sabiri, she's a pharmacist here at UCSF that we've been collaborating with. She and her team have developed this program called the PrEP Optimization Intervention. And it has two key components. It's a combination of an online panel management system to help providers track all their patients on PrEP and when they need to come back for follow-up visits and labs. but it also has a PrEP coordinator who sort of helps with PrEP navigation, coordination of care. And really the idea is to help offload busy primary care providers who may not have time to be tracking and following up with patients. So this is being tested in over 10 public health community clinics in San Francisco using a stepped wedge design. And follow-up just completed in the study, so be on a lookout for the results. But she has published on some of the qualitative data and interviewing the medical directors and other staff across the clinics. And it's really been quite positive. The title of the paper is actually, "You Can't Have a PrEP Program Without a PrEP Coordinator." And so two of the quotes from this paper, one is, "So this feels night and day in terms of somebody monitoring follow-up and reaching out to patients, because if we don't, 90% of our patients are not going to come back in after the 90 days if someone doesn't reach out to them." And then another provider said, "It took so many things off of my plate. So I'm there to be able to do the medical assessment. She's able to do things that don't have to be done by a physician, after visit work that needs to be done in order to ensure that patients are able to get their medication and take it appropriately and follow up. None of that has to be done by a physician." So I think this task shifting can really help offload providers and really have a systems approach to supporting patients on PrEP across busy clinics. So now I'm going to move on and talk about some novel PrEP delivery models. So one that we've just kind of started in the last year piloting is this idea of same-day PrEP, but with the provision of generic TDF-FTC. So at CROI this year, Dean and colleagues presented a poster showing on what's called pharmacy reversals. So the idea of, when the prescription is prescribed by the provider, but the medication's never picked up or isn't picked up by the pharmacy. So they were actually able to track this within a large nationwide study of over 50,000 PrEP users using national claims database. And they found that 19% of prescriptions were never picked up. And among those, 29% of patients had a delayed PrEP initiation, 90 days or more. And at the same time, we've seen that several studies have shown that providing PrEP, same-day PrEP, can be safe, acceptable, and can help facilitate PrEP starts. And there have been some studies also showing that provision of free medications for PrEP or for other conditions can help reduce structural barriers such as lack of insurance, medication costs, getting to the pharmacy. So there's this large RCT done in Ontario, Canada, where they provided a number of essential medications, like for diabetes, hypertension, hyperlipidemia. They provided that at no cost to folks randomized to this free medication arm. And they found that adherence to the medications increased across a number of different medications. And then for blood pressure, they actually showed better blood pressure control in the group that got access to the free no-cost medications. So with the recent introduction of generic PrEP, we've seen really dramatic declines in the cost of PrEP down to $30 a bottle. And so the San Francisco Health Department, as well as the Alameda County Public Health Department, have begun to pilot the idea of purchasing batches of low-cost generic PrEP and distributing this medication to clinics that are self-serving some of the most vulnerable populations that may have trouble getting to going to pick up a medication. So far the staff and it seems like they really appreciate this offer, this option for patients, and that they can leave with a bottle in hand. There's also been a rapid growing interest in telemedicine, especially in the era of COVID-19. This is a study by Aaron Siegler, who's currently evaluating a telemedicine model where PrEP users can get lab testing done through a mail-in kit and have a telemedicine visit with a provider. They're doing a large RCT right now, but in an earlier study, this model was shown to be highly acceptable in young Black MSM, and you know, 2/3, 67% said that they were more likely to remain on PrEP if this ePrEP model were available. Another innovative model is delivering PrEP through pharmacies. And in 2019, in California, SB Senate Bill 159 was passed, which allows pharmacists to, on their own, to initiate up to 2 months of PrEP. And so in San Francisco, one of our collaborating pharmacies, Mission Wellness Pharmacy, is, really took the lead on this and provides this one-stop PrEP approach. And this includes, doing labs, providing the prescription, and providing linkage to follow-up care. And it's really been a successful model. We're sort of taking this one step further through Susan Buckbinder here has a study that's currently ongoing to study a digital pharmacy model of PrEP delivery. And so we're partnering with Alto Pharmacy, which is this online pharmacy that delivers medications by courier to individuals throughout the Bay Area. And the way it works is that for this study, we have a collaborative practice agreement established with the pharmacist, and so they can do the initial assessments, provide the PrEP prescription, and then they can also order and track labs. So we're collaborating with molecular testing labs that will send kits to people, and they can at home and they can do the testing, or they can go to a local lab if that's what they prefer. And they have a beautiful app where patients can schedule medication deliveries and track. You can track real time where the courier is, when they will show up. And we've built into this some PrEP specific components, including pill reminders, as well as the ability to message back and forth with the pharmacist. And that's one of the components that participants seem to like the best, is having, being able to talk with a pharmacist and with any questions that they have. They really appreciate the support. So as we mentioned earlier, transgender people are really a heavily impacted group by HIV and have lower PrEP uptake. So the CHRP, the California HIV/AIDS Research Program, funded several demonstration projects in California, including one in San Diego that Jill has been working on. And so we had one in the Bay Area called Stay Study. This was a demonstration project among trans and non-binary people across several clinics. And these are data highlighting why a project like this is needed. This is looking at the PrEP continuum, comparing trans women and MSM in San Francisco. And so the trans women data are in red and MSM in purple. And you can see at each step of the continuum, so PrEP awareness, having talked with a provider, actually using PrEP or being on PrEP, and then being on PrEP and reported self-reported adherence to PrEP, that you can see at each step of the continuum, there are lower rates in trans populations compared to MSM. So we, in this study, we collaborated with 4 community-based sites that really have long-standing experience and relationships in building trust and providing care to trans communities. This includes the San Francisco Community Health Clinic, our Castro Mission Health Center, which is more focused on youth, Tom Waddell Urban Health Center, and then Tri-City Health Center in the East Bay. And this is just showing our team. It was a largely peer-led team where the peers really engaged with participants and provided ongoing support. And while we were successful in each of the clinics in establishing and growing their PrEP programs, there were also a lot of unanticipated challenges with PrEP implementation in the clinics. First of all, there was a lot of turnover of staff. In fact, 2 of the 4 site PIs had actually changed during the project. We also noticed within our own DPH clinics that there were a number of barriers to getting even established in the clinics, where people had to jump through numerous hoops and visits before they actually, through the 6-week orientation process before they could even see a provider. There were differences in who providers thought were a good PrEP candidate. And so sometimes we would say, oh, this person would like to start PrEP, but the provider said, oh, no, that person's not at risk. And finally, just, as more and more people got enrolled, the quarterly follow-up visits became a burden for both the providers and the clinic staff. So midway through the study, we sort of did a real-world adaptation, and we came up with the idea of forming a trans-specific PrEP clinic outside of primary care settings. So we located this within our HIV prevention research clinic within the Department of Public Health, where we have a dedicated waiting room, more flexible hours in the clinics. And this was led by really our peer, trans peer navigator, as well as a team of NPs who provided support for the clinical support for the visits. And we found that, the other sites have been enrolling for over 1.5 years. So the first 4 sites, you can see here the number of participants they enrolled. Within 4 months of starting up this new PrEP specific model, we had more enrollments than several of the other sites that had been recruiting for over 1.5 years, which you can see here. And we were also reaching a different demographic. And so these are different characteristics of participants enrolled at the primary care sites versus at the TransPacific PrEP specific clinic at Bridge HIV. And you can see that at the PrEP specific site, we enrolled participants who had higher numbers of sexual partners, were more likely to be engaged in sex work, use drugs, as well as higher rates of depression, anxiety, PTSD, and then lower rates of being on PrEP at baseline. So we're more likely to reach PrEP naive individuals. And these are some quotes from participants about why a PrEP clinic for trans folks works, and that, even though they are getting trans-specific care within primary care, that they like this because this is just really focused on their needs in PrEP, and that, the PrEP-specific clinic can help with, provide better help with some of the navigation issues. An interesting thing that we didn't anticipate was that a number of participants said that they didn't want to tell their primary care doctor about all, their HIV risk around sex work and using drugs, because they didn't want to jeopardize their hormone, or if they were on a surgery path, they didn't, want to jeopardize that. And so they liked the idea that they could just separate out the PrEP part as well. And here you can see some other quotes from folks that they didn't feel judged about their sexual behaviors. The peer support was really helpful. And one participant actually had been kicked out of primary care. And so this was the only place they felt comfortable accessing PrEP. So finally, I was gonna talk about our recent efforts to try to develop a regional approach to PrEP implementation. You can see in San Francisco and Alameda counties are the two counties that are most heavily impacted by HIV. And while we've seen a decline in new HIV diagnoses in San Francisco, in Alameda, it's really been stable over the last decade, and they've had over 200 new infections in 2019. And so we really need to have a regional approach to get to zero. And so we recently have started using this equity-based framework for implementation research. And it's a model that it's people-centered. You can see people here at the middle. And you start by, working with community and identifying, which groups are disadvantaged and quantifying current health equities, and then working together to come up with equity-based recommendations and strategies, which you can then test out and looking at different implementation outcomes. And so we've started doing this, looking at data within the Bay Area, and we've identified several populations that are where there are significant gaps, and these include youth under 30, Latinx and Black individuals, as well as people experiencing homelessness, which is substantial. They make up almost a fifth of new HIV infections in San Francisco. So one project that we've been doing through a CFAR supplement is to try to bring services out to community, and particularly people experiencing homelessness, through a mobile testing program that they've developed, and that primarily has been focused on HIV testing, but we're really now trying to build in status neutral care to that, including both rapid ART as well as PrEP access based on how their testing results. So actually the last thing I will end with is implementing an anti-racist approach to PrEP. And so Ibram Kendi has described in his book, How to Be an Anti-Racist, that ideas and policies are either racist or anti-racist. And racist policies are the cause of racial inequities, including health inequities. And specifically in our case, inequities in HIV incidence and PrEP. And so I think it's critical that we examine all steps of our PrEP continuum to ensure that PrEP delivery is anti-racist and aiming to achieve equity, and to counter the racist and inequitable structure of our healthcare system. Julie Myers and colleagues in New York have developed this PrEP Equity Index, where you can help set local targets for PrEP coverage to not just get levels up to equal levels across of PrEP use across different groups, but to actually achieve targets that will lower HIV infections across all groups. And so they showed, for example, that PrEP use would need to increase by 65 to 295% in Black MSM and 130 to 230% in Latinx MSM to achieve equity with white MSM in New York City. So we're trying to take a similar approach in San Francisco and calculate the PrEP Equity Index in different groups by race, ethnicity, gender, identity, and gender, age, and also housing status. So to conclude, PrEP is a promising approach to ending the epidemic, but there are significant disparities in implementation. PrEP persistence is suboptimal across a number of clinical settings with high HIV risk after discontinuations. And there are multiple structural barriers that limit the potential of PrEP and may exacerbate disparities. A people-centered approach to PrEP can help address barriers, and it's important to consider additional support strategies for both clients and providers, as well as some novel delivery models which can help achieve equity and maximize the impact of PrEP. And also just to think about implementing an anti-racist approach to PrEP in your practice or jurisdictions. And these are just the many acknowledgements of folks who have helped contribute data and slides for this presentation, and particularly want to thank the study participants in our studies, as well as the Getting to Zero PrEP Consortium, both in San Francisco and in the East Bay. And with that, I will stop.
Al, you've got a clap from Dr. David Moore and Dr. Darcy Wooden. I'm not going to say everybody who claps. The first question I have is, where can I get that life-size PrEP pill? That's great. So the chat was quiet, but I mean, I have a lot of questions. I'm sure other people will unmute themselves. I do want to start with something that's come up a lot in our PrEP clinic and beyond, that Ryan Anson brought up, and that we've been thinking about a lot. You brought up 2-on-1, which we are using. I think the trouble or the question is, can we use Descovy with 2-on-1, which is probably at least for cis men who have sex with men and transgender women, I'm going to say 75 to 80% of our prescriptions, if not higher. So if you're considering 2-on-1, which currently is only been shown to work for Truvada, what's the practice looking like in San Francisco currently?
Yeah, that's a great question. Many clinics are still prioritizing Truvada as first line, and offering, I know that at our STD clinic, as well as I think Magnet, are the big community-based PrEP provider, that Truvada is still first line, and Descovy is reserved for, people who have renal or bone issues, or, otherwise if their insurance, requires it. So it's still a smaller proportion of our overall PrEP prescriptions. And for folks who want to use 2-on-1, we have restricted that to Truvada. I did recently ask Mobley Das about this, because it is coming up a lot, and she shared some PK data, which they have, I think some of it's been presented in various forms about, the PBMC, the intracellular levels with Descovy go up, very quickly, compared to with Truvada, and as well as, they get much higher intracellular levels, as well as over time, because they reach a higher level, the decay, they persist above. I think they used a 40 femtomoles, or 40, a cutoff of 40 within PBMC levels, and it showed that instead of 10 days, it was 16 days above that. So I think, and they said that they're actually now doing their studies looking at, instead of 2-1-1, they're looking at 1-1 with Descovy, because it achieves higher levels, and they don't think people have to take 2 doses. It could be 1 dose and then only 1 dose after. So there's studies now looking at 1-1 dosing with Descovy, but there's still studies. So
right. And that was the next question of what studies were out there. It's really interesting that at least, our practice is very different. And I know that there's a cost benefit. I think we use the PK data that you're describing, that has shown that it should be sufficient. But because we are using Descovy so much more, it would then be really hard to say, well, you can have your Truvada on reserve when you want to go to 2-on-1. You can't really, so easily toggle back and forth between medications.
So are you prescribing 2-on-1 with Descovy?
You didn't hear me say that. No, we are. I would say it's a minority, it's definitely a minority of our patients. But we tell them it's off label, but that we are, highly convinced by the PK data that they'd be protected with it. So I don't know if anyone else wants to speak to that. That's definitely been our practice within our clinic. And I know you heard me bemoan this years ago. We now have served, many hundreds of patients. So it's, without any seroconversions to our knowledge so far.
Yeah, we
But
have had a few seroconversions with Truvada 211 where people, get mixed up about the regimen,
yeah,
and that's been unfortunate.
right.
Can I ask a question?
Yeah.
Oh, Darcy.
Thank you so much. Your talk was absolutely outstanding, and all of the work that you and folks in the Bay Area are doing. I am not a PrEP provider routinely, so I apologize for the ignorant question, but I'm just wondering. I really loved your people first approach, and sort of everything that you described, and also making sure that you're having an anti-racist and really addressing disparities in kind of every aspect that you do. Obviously very exciting with cabotegravir, results coming out in the New England Journal this week in terms of how efficacious it is. I do worry that there are a lot of opportunities to widen disparities with cabotegravir, given costs and requirements for administration in clinic and things like that. So I'm just wondering if you've kind of already been sort of thinking about and working on ways to make sure that, once CAB is approved for PrEP and is, in more widespread use, how to specifically make sure that it's decreasing disparities and not increasing.
That's a great, wonderful question. We are just starting conversations around CAB and CAB implementation, and actually more so right now with Cabenuva for treatment, because that is approved. And so far we found at our HIV clinic that it's the uptake has been really low overall. I think they have like one patient on it, and it's there's just so many challenges. I mean, it requires many more visits than for oral treatment. So it's going to put more burden on the system, and you're right, it could exacerbate disparities. So I think there needs to be a lot of intentional implementation science around this with an equity frame to think about how best to what can be done to roll out this in an equitable fashion. One approach that we have a grant through ViiV for injectable treatment to sort of expand that the model I talked about for the PrEP trans specific clinic. We were going to create a similar clinic for injectable treatment where folks can just come to the clinic for their injectable treatment, come in and out, and potentially do mobile, like go out to people through mobile vans and try to eliminate some of these barriers. But it's going to really take I think some careful study.
Thanks, Al. Again, a little bit of a different experience here. I don't know if Lucas Hill is still on. He is our head pharmacist at the Owen Clinic. When I just checked in with him about our Cabenuva numbers, and ours are more in the 30s.
Oh, wow. That's great.
Yeah, they've worked really hard to try to mobilize this, and still, we just spoke about 120 people on a wait list, really waiting. I think the big barrier there is that it's not yet on the ADAP formulary. And that's a very big barrier for people who either have ADAP as their primary or their secondary form of coverage.
Yeah, hey Jill, I'm on.
Yeah, sorry.
No, you're fine. Yeah, we've had about 150 people express interest in Cabenuva, and like you said, we have about 35 now on Cabenuva. But I think the other thing too with injectable CAB for PrEP, it is going to be every 2 instead of every 1, which is a little different. But I think then that also introduces a little bit of awkwardness in the follow-up schedule, because you're doing the every 3-month visits and testing and now, but then the injectables in every 2 months, and could we maybe alter the way we schedule follow-up and monitoring around fitting that every 2-month schedule for the injectable? But yeah, there's been a lot of challenges to Cabenuva, and I think the same ones are going to present with injectable Cav Prep too.
Yeah.
And I want anyone else, there are a lot of people that you know on this call. I don't know if they have any questions. I realize it's also the top of the hour, so some people are starting to get off. I don't know if anyone else wants to unmute themselves and ask Al questions.
Well, I had a
There
question.
you go. I had a feel. Oh, did someone else speak besides David?
It's me, Anthony Coronado.
Oh,
So
Anthony, why don't you go first and then we'll pass it over to David.
Okay, sorry about that. Sorry. Al, I had a question. So in the Bay Area, when a lot of the barriers for individuals accessing PrEP are staying on PrEP, you mentioned loss of insurance. Are those individuals who are losing insurance linked into PrEP app or anything like that? Can you talk a little bit more on that?
Yeah, we're trying to do that, but I think there are a number of hoops to jump through to get on PrEP app as well. And some people, we've had patients that are like, oh, it's just too complicated. I can't do this, or I don't want to do this. And that sort of inspired this idea of, could we just give people drug? Or it takes time. And so, they lose their insurance and it's going to take several months to get them back on. But we definitely have a great team of navigators that, try to find ways to get them back on coverage. But it can be an onerous process for some people.
Thank you.
All right, and then David, it'll be the last question and exchange, and then we'll go.
Great to see you, Al. Wonderful presentation as always. You and your team, expanded large team, are doing amazing work. So thank you. You mentioned implementation science, and then in other parts you mentioned kind of trying to increase the equity of delivery of PrEP. I'm wondering, just thinking about areas like the South of the United States where there's huge inequities, how do we get better scale up of some of your, effective and efficacious interventions in areas that are, in the highest inequity groups in our country, or even within our state? San Francisco is so resource rich. It may not feel like that to you, but it really is. So I'm just curious your thoughts on that.
Yeah, that's a great question. I do think that there can be more partnerships that happen, between groups to help, share some of the resources. That's partly what we were trying to do, even with the East Bay regional approach. There's, another project that the San Francisco AIDS Foundation recently started as a partnership with Fresno to sort of offer telemedicine and teleprep and telerapid services to, I think they just have fewer clinics and fewer resources there. And so try to offer that. I think in the South, there are a number of challenges, and, things can be more spread out in rural areas as well. And so I think there is a power of using these mobile technologies. But it's also, trying to overcome a lot of the structural barriers that, that is really challenging. That, a number of folks are trying to work on that as well.
Wonderful, thanks.
Well, thanks so much, Al. And for those who've stayed late, I think if there are any other questions, Al's very reachable. If you can't find him, you can ask me, send an email to me. But Al, thank you so much for joining us and sharing all the work that your team is doing in San Francisco and outside of San Francisco. And thanks for joining us so early on a Friday morning over the summer.
Great. Well, thanks so much.
We'll have to get you down to San Diego soon.
Oh yeah, that would be lovely. Yeah. Okay, take care, everyone.
All right. Bye, everybody. Have a good rest of the day and weekend.